Hello, and welcome to another episode of Hematology Horizons. My name is Elissa Baldwin, and I'm the Director of National Patient Education at Blood Cancer United, formerly the Leukemia and Lymphoma Society. Today, we are on site at the University of Colorado Anschutz in Aurora, Colorado, to learn about the exciting advances in CAR T-cell therapy for blood cancers. We are joined by Dr. Terry Fry, a hematologist and the Executive Director of the Gates Institute at CU Anschutz. Later on in the episode, we will be talking to Dr. Mathew Angelos, a hematologist-oncologist at the Cancer Center, with an update on CAR T-cell therapy for acute myeloid leukemia, or AML. Welcome, Dr. Fry.
Thank you.
Thank you for being here with us. So our episode today is on CAR T-cell therapy. Could you tell us what CAR T-cell therapy is?
Yeah, broadly it falls in a category of cancer treatments called immunotherapy. And there's a number of different examples of immunotherapy, but more specifically, CAR T-cells involve the process of genetically modifying, inserting a gene into a T-cell that enables the T-cell to target cancer. So what's a T-cell? So a T-cell is a type of immune cell that is typically involved in fighting viruses such as COVID. And occasionally, T-cells can recognize cancers. And so with a CAR T-cell, we enable that to happen through the insertion of this gene that allows these T-cells to find a cancer cell and kill a cancer cell.
And so what blood cancers are currently eligible for CAR T-cell therapy?
Right now, in terms of the approved products, the products that are approved by the Food and Drug Administration, the cancers that are targeted really fall into a broad category of cancers that involve B lymphocytes, B cells in the body. So specifically, these are cancers such as myeloma, lymphoma, and acute lymphoblastic leukemia.
Are there specific diagnoses within lymphoma that are approved right now?
Yeah, so the original trials, so I'm actually a pediatric oncologist, and I'm proud to say that actually the first indication for CAR T-cells was actually a pediatric indication, pediatric acute lymphoblastic leukemia. And the next indication was a specific subtype of lymphoma in adults called diffuse large B-cell lymphoma. Both of these approvals were in 2017. So since 2017, the group of cancers that can be treated with CAR T-cells has expanded based on subsequent clinical trials. So now beyond diffuse large B-cell lymphoma, mantle cell lymphoma, follicular lymphoma are all included in the labels for different CAR T-cell products.
That is just wonderful. It's great to see them expanding, and we'll talk about emerging therapies and clinical trials a little bit later. So are there other factors that you're looking for when determining if a patient is a good candidate for CAR T?
Yeah, so I mentioned earlier that the concept of a CAR T-cell is genetically modifying a T lymphocyte to recognize a cancer cell. And what that modification allows that T-cell to do is to recognize proteins that are expressed on the surface of specific types of cancer. In the approved products, CD19 or for myeloma BCMA are the name of the proteins that are targeted. So obviously for these T cells to work, that protein has to be expressed on the target on the cancer cell. So generally it is, but we are finding that if you look more carefully at individual patients, the expression of those proteins can be variable from patient to patient. And so one important factor that is emerging is a careful assessment of what proteins are expressed on the patient's cancer.
Okay, so even if you do have a diagnosis that is eligible, that doesn't mean that your cancer would be necessarily good for CAR T-cell therapy.
B-cell malignancies, I mentioned that as a broad category, in general tend to express CD19, right? So, and particularly when they're initially diagnosed. there's a number of emerging treatments, even beyond CAR T cells, that are immunotherapy treatments, antibody-based treatments, et cetera, that target these proteins. Unfortunately, we've learned over time that cancer cells can evade therapies. And so one of the mechanisms of evasion is loss of CD19, the protein that's targeted by CAR T cells. So ensuring that that protein is expressed is an important part. It is not something that was necessarily appreciated in the beginning of the field, and it's not a requirement within the label, but I think as an oncologist is assessing whether a patient is a good candidate, it is something that's important to look at.
Okay. And I know a lot of our patients ask about age and maybe just general fitness and health. Are there any factors like that that may exclude them from CAR T cell therapy?
So when somebody has a viral infection, we all know that you can feel pretty lousy, you can have fever, you can get sick enough that you end up in the hospital in certain situations. That is, not from the infection, that is the immune response against the infection. CAR T cells, when they're doing what they're supposed to do, that is to say killing a cancer cell, can drive many of those same symptoms that happen in the context of a viral infection. And we give the name to those toxicities, cytokine release syndrome, or ICANS is the neurologic toxicity that happens with CAR T cells. We can talk about that in a minute. So one of the important factors when evaluating a patient for CAR T cells is considering whether that patient is in a position to be able to tolerate what could be pretty significant inflammatory side effects.
So before we get into the latest advances in CAR T cell therapy, I'd like to dig a little bit more into the side effects. So you mentioned a couple side effects. Are there any others that patients can expect, and can they be managed?
Yeah, so cytokine release syndrome is one that I mentioned. It is sort of the systemic inflammation that goes along with an effective CAR T cell response associated with fevers, muscle aches, again, the things that you typically associate with a viral infection. In its most severe form, can lead to changes in blood pressure that might even necessitate stay in the intensive care unit. ICANS is a neurologic toxicity, also thought to be inflammatory. It is inflammatory in nature, although the specific mechanism is not entirely understood quite yet, but it involves things like confusion, difficulty finding words, interestingly, as well as other neurologic manifestations. So those were I would call them class toxicities that emerged, in the initial experience. And we have actually gotten quite good at, one, managing them, and two, identifying certain risk factors for those things to occur. And one of them is actually the amount of cancer that a patient has, because the amount of cancer will potentially drive the severity of that inflammatory response. So that is certainly a factor that can be important in evaluating the suitability of a patient for a CAR T cell, and is a consideration. Over time, we've certainly identified that there are other potential side effects of CAR T cells that didn't necessarily show up in the initial clinical trials, or maybe they did and we didn't quite notice them. One toxicity that's being looked at carefully is that patients can have low blood counts that can include white blood cells, platelets, that can extend into the second month after CAR T cells. Generally manageable through growth factors and other types of support, but certainly something that we're all paying attention to.
So it sounds like most of these side effects will probably be in that first month or so?
The ICANS and the CRS is typically within the first 2 weeks, 2 to 3 weeks. That the low blood counts, as I said, can extend out into the second month, but generally all these toxicities are within the first month or two after CAR T cells. Now, it would be unfair to say that we totally understand whether there are longer-term sequelae that could be associated with CAR T cells. There's one in particular that we do know happens, which is that I mentioned earlier that the target for CAR T cells, for the approved CAR T cells, are expressed on B cells. B cells are actually normal cells in the body as well, and they produce antibodies. And so if the CAR T cell does what it's supposed to do, in addition to killing cancer cells, they will also kill normal B cells. And so patients can have low antibody levels in their blood for an extended period of time, and sometimes require management with antibody infusions to be able to maintain that. And that can be months to a year or beyond. So that can be a long-term toxicity, but again, can be managed pretty easily. Other toxicities, for example, long-term cognitive effects of CAR T cells, et cetera, have not been readily apparent, but there are some ongoing studies to look more carefully as to whether there are subtle side effects that weren't seen so far.
That is very good to know. Now, let's discuss the future of CAR T cell research. Are there any newer CAR T cell therapies or those in clinical trials that you're particularly excited about?
When you think about CAR T cell in its current form, the approved CAR T cells, in a way, it's a very different and remarkable drug in the sense that every patient has their own drug made for themselves. These, the approved products are what are called autologous, meaning that we collect cells from the patient. We perform that genetic modification that I described earlier outside the body. The cells are expanded, they're frozen, and then they're given back to the patient. So each patient has their own drug, basically. And it's pretty unique. I mean, prior to CAR T cells, there really was nothing like it. And in fact, I think many of us at the beginning sort of struggled to envision how this would result in widespread use or uptake of this particular therapy. But obviously, the field has been able to solve many of those challenges. However, it is not the case that all patients necessarily can get their own autologous CAR T cells for various reasons. There's a 2 to 3 to 4 week delay in manufacturing the CAR T cell product, and certainly in parts of the world, it can be difficult to access CAR T cells. So one of the major streams of work beyond thinking about how CAR T cells can be used in different forms of cancer is thinking about how to improve the accessibility of CAR T cells. And that could be achieved through being able to generate a cellular product that could be divided into multiple doses, and that same product could be delivered to multiple patients. That's called an allogeneic CAR T cell, and there are trials that are ongoing and are pretty far along, and it's likely going to be some approvals in that space. The other really remarkable advance has been the ability to generate CAR T cells within a patient's body, essentially delivering to the patient the usual machinery that we use to perform that genetic modification, and instead of performing it outside the body, performing it inside the patient, so-called in vivo CAR T cells. And there are actually some very early clinical trials with that approach. So I think one of the things I'm excited about are going to be modifications to the therapy that will allow us to improve access, because these therapies are highly effective, and I guess my own bias is that any patient who has a cancer that could potentially benefit from a CAR T cell should have access.
Now, we're going to talk to Dr. Angelos in a moment about the difficulty with myeloid malignancies and AML in particular. But are there any other types of blood cancers that are being studied right now that are not approved?
Yeah, so myeloid malignancies, other forms of leukemia, T cell leukemia. So T cells, remember I said T cells are how we make the CAR T cell, how we make a CAR product, but T cells can also be a source of cancer. And so T cell leukemias is another blood cancer that we've been focused on. Certainly thinking about other forms of lymphoma outside of the B-cell lymphomas has been another area of interest. Obviously solid tumors outside of the context of what we're talking about today, but is another area of excitement.
Well, that is so exciting. So many different avenues of CAR T-cell therapy that we can look forward to. So that's great. Now we're going to pop over to Dr. Angelos for a moment, and we will be right back with you.
Sounds good.
We are now joined by Dr. Mathew Angelos, a hematologist-oncologist at CU Anschutz. Welcome, Dr. Angelos.
Great. Thanks for having me.
Thank you for speaking with me today. Before we get into the latest advances, why has it been difficult for CAR T-cell therapy to be successful with myeloid malignancies like acute myeloid leukemia or AML?
Mm-hmm. Yeah, so for myeloid malignancies, they are much more difficult to treat with cellular therapies as compared to other blood cancers like lymphomas or multiple myeloma. And one of the main reasons for this is that we don't have a very robust and highly expressed surface antigen that these CAR T cells can target. So analogous to those other diseases, myeloid neoplasms don't have a very good target to really go after, we have found to date. And so because of this, it makes it very challenging to engineer in the lab a construct that can go after and successfully hone in on myeloid cells to then go about and clear out the disease. There's been a number of studies that have been conducted in the past 5 years or so that have looked and tried to identify such antigens, and there is some activity with those types of approaches, but we really haven't found the magic bullet just yet for myeloid diseases. And so, this is a big challenge in our field. There's ongoing target discovery for which our institution here has a novel target that will be moving into clinical trial shortly that we hope will be successful. And there are other strategies that we're now starting to employ to just get around this issue of trying to target a single molecule on the surface of a leukemia cell that we hope will be successful in the future.
Mm-hmm. So you're looking at for a target that's different from just normal cells in the body, right? That would just be just on a blast, a leukemia blast?
That's correct, yeah. So one of the challenges so far is that we haven't found a good, unique antigen target that is specific only to leukemic cells, but not so much to those normal, healthy blood cells that are inside the marrow and give rise to a hematopoietic system that is needed for patients to essentially function. We have ongoing efforts to really try to hone in on the right matured antigen in the right patient populations such that we can have on-target precision against the leukemia, but not against patients' healthy cells that are in their marrow. And the goal of this is to try to prevent long-term marrow dysfunction, propensity for infections, and also the need for patients to get blood transfusions, both red cells and platelets. Trying to minimize on that need really would help to improve not only outcomes against leukemia, but also patients' quality of life moving forward.
Now, I'm sure that our patients and caregivers that are watching today would like to know if there are any updates on CAR T-cell therapy for AML.
Yes, for sure. So this is one of the areas in which I have an active research program here at the University of Colorado. And I'm pleased to share that our institution here will be conducting a first-in-human phase 1 clinical trial that's opening this summer. This is a study that is actually generously supported in part by a grant that we received from Blood Cancer United. And the premise behind this study is that we'll be looking at a novel target, which is called CD64. This is a target that is expressed in a specific subset of acute myeloid leukemia. And we found from research done at our institution that it looks like it's a really good marker for a select number of patients. It's uniformly expressed, it's highly expressed in the right contexts, and it's not expressed on those healthy hematopoietic stem cells, like I said, that gives rise to all of the normal healthy blood cells that patients need to function. And so we think in combination of treating the right patients and in using this novel target, this will really be a nice approach for patients that have relapsed or refractory acute myeloid leukemia. And our goal is not only to get patients into a remission and ideally cure their AML, but also this is aimed at trying to improve quality of life of patients as well, trying to minimize ongoing chemotherapy needs, ongoing needs to come back into clinic, and ongoing needs to get what can be often lengthy appointments and also transfusions that patients need to get as a part of their disease treatment.
Now, are these for particular gene mutations? Because I know there are so many different gene mutations with AML, and they all kind of present differently and respond differently to medications.
Mm-hmm. That's right. So the premise behind this study here is to look at individuals that have failed an initial AML therapy. What's become standard of care in our field is to offer patients a combination of two drugs, one of which is called a hypomethylating agent, drugs like azacitidine or decitabine. And we do that in combination with a pill called venetoclax. We have found that patients that relapse after receiving a frontline standard of care combination with venetoclax tend to take on more of a monocytic flavor of AML. And a monocytic phenotype is a subset of a myeloid leukemia. It's kind of like looking at a gumball machine and maybe just picking out maybe just the green ones. That would be analogous to what AML looks like, and we're just picking off the monocytic ones. And our group on campus has found that individuals that have this monocytic flavor have really high and robust expression of CD64. So with this trial, what we're trying to do is we're trying to take away this complexity of AML, and we're trying to deliver what we think is an excellent target, specifically within the right patient cohorts. We found that in other phase 1 studies, because of the heterogeneity of acute myeloid leukemia, there's not universal responses that we've seen on those trials. And so we think by using the right target in the right patient population, our hope is that we're going to see ongoing success with cell therapies in AML.
Very exciting. Well, thank you so much, Dr. Angelos, for telling us about this new trial coming up. I think that presents a lot of possibilities. Very exciting, and really appreciate you joining us.
Great. Thanks so much. We're very excited.
Thank you. Welcome back, Dr. Fry. You and Dr. Angelos have shared some very exciting updates on CAR T-cell therapy. To finish up our conversation today, what would you say to patients and their loved ones who might be considering CAR T or have already started the process to give them hope for the future?
When I look at, sort of my career, I would say that, I've been very lucky to be in the field of, cancer immunotherapy, at a time when something like CAR T cells have become available for patients. When we look back at the initial, clinical trials testing CAR T cells, many of us who were involved in some of those earlier studies were hoping for the types of things that you typically see in an early phase clinical trial with a new cancer therapy, which is to say that maybe if you're lucky, a quarter of patients will have some benefit, meaning some shrinkage of tumor or some reduction in the amount of leukemia that they have. The amazing thing about those original studies was that in the pediatric trials, the initial pediatric trials that led to the approval of the first CAR T cell for pediatric cancer, it wasn't just a reduction in the amount of cancer. It was a complete eradication of cancer cells in 80+% of the patients who were enrolled in the study. I mean, in many ways, almost unheard of in the context of early phase clinical trials. I mean, we've certainly learned that not all patients stay in remission. We do recognize that a subset of those patients that go into remission may relapse. But we've also learned that there are a subset of patients who will stay in remission long term. And I always hesitate to use the term cure, but I think we're getting far enough into this field that I think it's safe to say that many of the patients that were treated initially and they're still in remission are probably cured of their cancer. And so I think for an individual patient, I think, a CAR T cell is not, potentially a life-prolonging treatment. It is potentially a curative treatment.
That is just absolutely wonderful, and what an incredible, innovative treatment for our blood cancer patients. I would like to thank Dr. Terry Fry and Dr. Mathew Angelos for joining us and sharing these exciting updates about the latest advances in CAR T-cell therapy for blood cancers. For more information on CAR T-cell therapy, please visit the link below. Thank you for joining us. We'll see you on the next episode of Hematology Horizons. Take care.